the program. So should we?
Yes, we should start.
We can start.
We can start.
So Aditi, you can share. Aditi, you can share the screen.
Hello.
Madam Ajan.
Hello. Yeah, I've joined. Good evening.
Good evening, madam.
Good evening.
Good evening.
Sorry,
Good
I just got over.
Yeah.
Suchitra, good evening. Good evening.
Good evening. How are you?
Oh, so fine. Looking like returning from border.
No.
Which border? Pakistan border or Bangladesh border? Or China border?
Bangladesh. I just had my talk there. So, at another webinar. That's
Okay.
join here. Okay. I'm ready whenever you are.
Madam, we are live now. Shall we start?
Yes, please.
Noise is coming. So good evening, doctors. I Shuman on behalf of Shield Healthcare, welcoming you all in today's medical session organized by the Association of Obstetrics and Gynecologists of Odisha. I would like to welcome all the dignitaries, our chief guest, our GO office bearers, guest of honors, chairpersons, speakers, and our moderators. So please show them. So it is my honor to introduce our moderators today, Dr. Varsha Vashnu, Madam. Madam is the MSOVG, Clinical Secretary, AOGO, and Madam is the Assistant Professor, Department of Gynecology, SCB Medical College, Cuttack. Madam is the Clinical Secretary, AOGO, and Madam Leader, MSOVG from SCB Medical College, Cuttack, and MBBS from MKCG Medical College, Parampur, Odisha. So with this short introduction, I request Madam to take over the session for further proceedings. So thank you very much, and over to you, Madam.
Thank you. A very good evening to everyone on behalf of AOGO. We welcome you to today's webinar. I would firstly like to introduce our President AOGO, Professor Dr. Tushar Kara. He has been the past chairperson ICOG 2019-20, Vice President FOXY 2010, Chairperson of FOXY Oncology 2004-9, has published many writings, authored 2 textbook Do's and Don'ts in OBGY and Safe Surgical Practice, and is recipient of many awards including Adarsh Chikitsa Award 2007, Manimanka Award 2010, Tarini Pratibha Samman 2015, and Best Original FOXY Journal Publication Award 2018. I would welcome Sir to give the welcome address for today's webinar. Please, Sir.
Thank you, Varsha, for nice introduction. I am really humbled to see all stalwarts are there. Good evening to all of you, including Suchitra, Sadhana, and all Dr. Hara Patnaik, Professor Lucy Das, Professor Maya Padi, Sasmita, our secretary, all the senior members of AOGO and from participants outside Odisha also. Yes, when this was decided, Sadhana told that which topic it will be better for all the practicing obstetricians, because I know that she has got a lot of work on maternal and child health. And you see, we selected that you go on to the labor. If you see the labor, understanding and the practice of the labor, that for last 2 to 3 decades, totally the understanding of labor has been changed. Now, if you look at the first stage of the labor, we started with the 3 centimeter. Laterally, it became 4 centimeter. Now, WHO up to 6 centimeter. Look at the change in the understanding of the only first stage labor. So, therefore, not only labor, but starting from the prenatal, intranatal and postnatal, everything is daily it is changing. So perhaps we decided that the best topic would be shift of paradigm in the management of the labor. So what are the changes so far, and how a practicing obstetrician should update himself or herself with the changing in the understanding of the management of the labor. So therefore, who is the best person? I think Sadhana is the best person in India in the Foxy level to deal with such a nice subject. I understand that with this beautiful and practical topic, all the postgraduates and the members of the AOG, or not only AOG, from outside Foxy members can be benefited very much. I again wish all the best for this academic extravaganza. All the best, Sadhana. Besides that, all the best, and also all the best for Suchitra for this. And already the play or the game has started from yesterday, and it is to be rolled. And let us see who is the scoring. So let's see and wait for that day 30th. And I again request all that you select the best person as per your liking. Thank you very much.
Thank you so much, sir. Now, I would like to welcome Professor Dr. Sashmita Swai Madam, our AOGO Secretary, Professor and Unit Head in Department of OBGY, SCB Medical College and Hospital, ex-professor and ex-professor and HOD in Balangir, IGNOU teacher and National Medical Council assessor. She has published more than 25 research papers in multiple indexed national and international journals and textbooks, and has special interest in high-risk pregnancy, infertility, and geriatrics. I would like to request Madam to speak a few words and introduce our chief guest.
Good evening, everybody. Respected our chief guest, Dr. Suchitra Pandit Madam. Today, our guest speaker, Dr. Sadhana Gupta Madam. Guest of honor, Dr. Lucy Das Madam and Dr. Maya Padi Madam. And chairperson of our session, Dr. Harapatnaik sir and Dr. Bhagyalakshmi Naik, and our president, Tusarkar sir. So today, it is a proud privilege that we have two stalwarts of Foxy among with us, along with our own society stalwarts like Hara sir and Tushar sir. It is really a pleasure to conducting this webinar for AOGO. So Suchitra Pandit Madam is a great academician. She has done her MD, DNB, FRCOG from UK, RCOG, and above all, she has also done B.Pharm. I found it very peculiar that Madam has also done B.Pharm. It is very unique that after MBBS doing B.Pharm also. And also there is nothing to tell about Madam. Madam has been the Foxy president. She has been the great academician, president of Gestosis India, chairperson of AICC RCOG 2017 to 20. President National ISOPAP 2018 to 20. There are many feathers to her credit. Many times we have Madam with us. From very beginning of my career, I have seen Madam coming to our society to present many papers. So we feel her to be one amongst us. So we are really privileged to have you, Madam, with us. So on behalf of AOGO, I request you to please share some of your experience and guide us how we can contribute to Foxy as you have done, so that by contributing to Foxy, we can also work for the welfare of our women. So this is my request. Please share some all of your experience, your knowledge amongst us, so that we'll be grateful to you. Thank you, Madam. I welcome again and also wish for your coming election for FIGO. Thank you, Madam.
Thank you, Sasmita. And let me tell you, you're very right. When you feel that I'm a part of Orissa, actually, I started my joint secretary's post as joint secretary to Dr. Usha Saraya, and installation was at Orissa, at Bhubaneswar. So, very much I feel I started my Foxy career. Though I was the member of various committees, I think that was the point of my starting in Foxy. And then onwards, I went up to young talent promotion and vice president, etc., etc. But what I'd like to definitely say that it's wonderful to be here in this particular webinar where you're talking of paradigm shift, and you have a very eloquent speaker, Dr. Sadhana Desai, to deliberate on this particular topic. I'd like to say a great big thanks to Dr. Tusharkar who did an excellent job as a chair of ICOG. He's a proud recipient of FRCOG and currently the president of AOGO and also the head of the department. So I've come several times to the SCB Medical College and we've done so many workshops and it feels very, very nice because everybody, likes to ask questions and there's a lot of interaction. So बहुत मजा आता है and I love coming to Odisha because then I can also make a trip to Jagannath Puri. So, to take blessings. So from here itself, I will request all of you to give my pranam to Jagannath Puri. And of course, Asmita, wish you all the best for your post. And I hope you also get elected to the Family Welfare Committee.
Thank you, madam.
And what to say about, two very eminent persons. The guest of honor, Dr. Maya Padi. Again, she was taking such an active role along with Sujata when we were organizing the first AICOG, where Dr. Patanaik was also there and Dr. PC Mahapatra organizing chair and treasurers of that AICOG. And now I'm happy to see she's the dean and principal of the SJMCH college at Puri. So we also have Dr. Lucy Das. She was also a part of the SCB Medical College and now she's a medical superintendent. So I'm sure Dr. Maya and Dr. Lucy together, you will have a conference at Puri and we'll all be there. And then another good friend is Dr. Hara Patanaik, who started this wonderful society of SOVSI, the Society of Vaginal Surgeons of India. And he's the honorary secretary. And I think the people were so much endoscopically inclined. So I'm very glad that this particular society has brought back the importance of the vaginal surgery. Thank you for that, Hara. And Professor Bhagyalakshmi. I think she's another gem from Odisha, like so many others. She's been chair of the Foxy Oncology Committee, but now she's the chair of the SAFOG. So she's also gone international and such a sincere professor of gynecology of the AHP GIC Medical College. And Bhagya, lovely to see. I've attended your webinars too. And I'm so happy, the entire team of Odisha is so committed for whatever they are doing. So it feels good, and I miss those wonderful rasagullas, which I used to. I'm sure you all will give us a virtual treat of the rasagullas. Thank you so much for having me here, because it's nice, that we have Dr. Sadhna to talk about this wonderful, this webinar, this particular talk. I wish her all the success, and I wish Sashmita also the success. And I hope all of you would also bless me with your vote. And after this, I'd like to say thank you so much, AOGO, for giving me this opportunity to be a chief guest. Thank you very much.
Thank you.
Thank you so much.
Thank you so much.
And Barsha, good luck to you. I'm happy to see you also come up now.
Thank you so much, ma'am. Now I would request our Joint Secretary AOGO, Associate Professor Dr. Ajit Kumar Naik, to please introduce our guests of honor.
Professor Dr. Maya Padi is presently the Dean and Principal at Sri Jagannath Medical College and Hospital, Puri, and she is today the guest of honor. And Madam Alku, Professor and Head, Department of Obstetrics and Gynecology, SCB Medical College, Cuttack. She was the scientific chairperson of AICOG held at Bhubaneswar 2018. Project Officer, Postpartum Center, SCB Medical College, Cuttack. She was the past president of AOG Cuttack. National Coordinator, FORCE 2011. National Coordinator, Foxy Son Initiative for PG Training 2011. Organizing Secretary, Foxy Journal, PGCME from 2005 to 2007. Also the Treasurer of AICOG Bhubaneswar 2002. Editor of prestigious AOGO Focus, started from 1999 to 2005. Attended and presented several scientific papers at various conference, state level, journal level, and national level. Is the author of chapters in several textbooks and publications in various local, national, and international journals. Has held organizational posts at several local and journal conferences. She is a life member of IMA, AOGO, ISOPAF, IAG, and Indian Menopausal Society. I welcome you, madam, to this webinar. Next
Thank you.
guest of
Thank
honor.
you for your kind words. Thank you so much.
Thank you, madam. Thank you, madam. Next guest of honor is Professor Dr. Lucy Das, who is presently working as medical superintendent of prestigious SCB Medical College and Hospital, Cuttack. She is also the professor and unit head, Department of Obstetrics and Gynecology, SCB Medical College, Cuttack. She was the president of AOGO, and she has presented many scientific papers in various national and international conferences. She has organized many conferences at state level and also at national level, and she has many publications at the national and international journals. I welcome you, madam, to this webinar as guest of honor.
Now I request our guest of honor, Lucy Madam, to speak few words to us.
Good afternoon to all. Revered Chief Guest, Dr. Nandita Palsetkar, Past President Foxy, Guest of Honor, Professor Maya Padhi, Guest Speaker, Dr. Sadhana Gupta, and President AOGO, Professor Tushar Kar, Secretary AOGO, Professor Sasmita Swain, all office bearers of AOGO, Chairperson, Dr. Harapatnaik and Dr. Bhagyalakshmi, and all the delegates. So really it is a proud privilege that we are having two eminent guests, that is Nandita Madam and Sadhana Madam with us. I think due to COVID pandemic, such thing is being possible. We don't have to book a date from them. We don't have to book a hotel, book flight tickets and all those things. Just ask them, are you free? Yes, we can start a webinar. So this is one good thing pandemic has given us. So anyway, AOGO, which was sleeping for last 2 years during my presidentship, probably due to pandemic, has now woken up in a very, very active way. And under the leadership of our dynamic president, Professor Tushar Kar, and
presidential candidate for next year. Presidential
yeah.
candidate Foxy for
Yes.
next year.
Definitely, I think that is
Your
already
blessing,
granted.
cooperation,
Yeah,
and best
definitely.
wishes.
And our dynamic secretary, Professor Sasmita Swain, definitely AOGO will reach to its highest level. And such type of webinars, seminars are being conducted very frequently now in AOGO, so that it is beneficial to all. And I wish all the best for the upcoming election for Nandita Madam and Sadhana Madam.
Sorry.
Suchitra Madam.
Suchitra Pandit.
Suchitra Pandit and sorry.
Sadhana Gupta.
Suchitra Madam and Sadhana Madam. And thank you all.
I request Maya Madam to few speak words.
Very good evening to all of us. I'm sorry if the connectivity may be poor as I'm traveling.
On the way from Puri to Cuttack.
It's a good 4 hours commute, going and coming. But anyway, so I would like to give my best wishes and welcome the dignitaries on this virtual platform. Dr. Suchitra Pandit, Dr. Sadhana Gupta, the speaker, and of course our very own office bearers of AOGO, the dynamic duo of Tushar and Sasmita. Any one person dynamic is enough in any association or any body to sort of galvanize everyone into action. But if both the secretary and the president in tandem are dynamic, well then, wo kya baat hai? So basically,
thank you very much.
Is now going through that lovely phase of that pandemic, very vibrant duo of Tushar and Sasmita, and we are seeing many academic activities in a span of a very short time. My best wishes to both of you to continue the academic calendar. Dr. Suchitra Pandit is well known to Odisha. She is a well-wisher of AOGO, and she is like almost like family to us. So I welcome you, Suchitra. And next time you are here in Odisha, pandemic is going down. We are hoping to see you there. I will personally take it on me to see that you can visit Jagannath Puri. That is my promise to you if I'm available and in town at that time. And of course, I will feed you the Rasagolas too, which you were remembering. And that's another promise to you. So, and the guest for, I wish you all your best in your election too, Suchitra. And I hope may that you win as the most deserving candidate. And Dr. Sadhana Gupta, we all know she's an eloquent speaker. And as the chief speaker today, she is going to touch on a very, very important and a very upcoming topic of the paradigm shift in the management of labor. Both the antenatal checkups, the antenatal care, and the labor management labor are actually undergoing a paradigm shift. The inverted pyramid of antenatal care, all of us know, and about the labor also, there is a lot of shift in the preventive aspect. The management gives the right of every woman so that it becomes a pleasant experience which she carries and cherishes throughout her life, instead of being the painful and the very undignified process it usually is. So we will let Dr. Sadhana Gupta speak on that. And thank you once again, AOGO, for putting me on this platform as the guest of honor, and my best wishes for AOGO and all the members of AOGO and FOXY who are contesting the election this time. Thank you so much.
Thank you.
Thank you, ma'am. Now I would request Professor Dr. Sashmita Swami, madam, our AOGO secretary, to introduce our chairpersons for today's talk.
So today we have two very eminent chairpersons to chair the very good session of Sadhana madam. We have Dr. Bhagyalakshmi Naik, my very good friend. She is now the professor department. She does not require any introduction, but as a routine we have to. She is the professor, Department of Gynecology Oncology, Acharya Haryara Institute. She was chairperson Oncology Committee, FOXY 2017 to 2020. She was a governing council member of ICOG at present, vice president AOGI in India, joint secretary AGOI, assistant editor Indian Journal of Gynecological Oncology, and executive member of East Zone ISCCP. She has received many awards, and at present, as Madam told, she is also the oncology chairperson of SAFOG. So welcome Bhagyalakshmi to the session. And we have another very eminent chairperson, Dr. Harapatnaik sir. He is a very dynamic AOGO member and our guide, and he is not present. He is a very dynamic Secretary General of SOPSI, which is so active because of his guidance and with Purna sir's blessings. We all are eagerly waiting for any academic need from SOPSI. So I need so many things to say. He is the president of Indian Menopause Society 2015. Vice President IMS 2012 and Secretary General IMS 2010, founder Secretary of IMS Odisha chapter. He was the governing counseling member of ICOG 2011 to 14, national corresponding editor FOXY Journal, chairperson Geriatric Gynecology Committee, president AOGO, and ex-secretary Health and Family. He has reached the pinnacle of his service also. So I welcome you, Harasa, to this session, to chair this session. So now I handed over to Bhagyalakshmi to introduce our chief speaker of the session, Sadhana madam.
Thank you so much. Thank you so much, Dr. Sashmita. I think I have no words. This has been a really very, very glamorous platform today with two giants of FOXY with us. So Dr. Sadhana Gupta and Dr. Suchitra Pandit. So it's always a very, very pleasurable thing to introduce Dr. Sadhana. I think she has the depth of knowledge of so many things I really can't tell you. And I think her talk will really ignite so many young minds now. So just to introduce her briefly, I think she has many, many major achievements. She has been the FOXY representative to SAFOG, ICOG Governing Council member, corresponding editor of Journal of Obstetrics and Gynec of India and SAFOG. She has been the vice president of FOXY, chairperson of FOXY Safe Motherhood Committee, FOXY representative to WHO, and I think so many things. And presently, She is the director and senior consultant of OBGYN Jivan Jyoti Hospital and Medical Research Center, founder, trustee of Jivan Jyoti Trust, Gorakhpur. I think she has achieved many accolades and academic honors like Chancellor's Medal for Best MBBS Student, recipient of 9 gold medals, Dr. Naval Kishore Gold Medal for Best Scientific Award in AICOG, thrice Dr. DC Datta Prize for the Best Foxy Publication. I think we cannot find any other befitting person to give the lecture today, madam. So I think I can go on and on. So let's not waste time describing her. Let's horse's mouth how she will talk, Sadhana, madam.
Thank you, Bhagyalakshmi, for kind introduction, and hearty thanks to Dr. Tushar and Dr. Shashmita for having this meeting, and my sincere regards to Dr. PC sir, Dr. Hara Patnaik, all the legend from the Foxy who have been really guiding force, and again the Katak and the Bhubaneswar has been in my memory because the first Korean award, which was like a first experience when I got the Korean award for the adolescent like awareness of the reproductive health. So it was something which many people at that time noted me first, and I was also looking back that no, I am for, like, I can do the things. So you know how the teachers and mentors actually inspire you. And what always Dr. Tushar, PC sir, Dr. Hara, so many people, Dr. Abhay Patnaik, Sanjay Das, Bhagya Lakshmi, they have been the part of our all programs, and we have a real good contribution. So many learned, like what we have observed, Dr. PC Mahapatra, what observation he has about what is happening in the world. And it is something really to imbibe from the great persons and the teachers like that. So with the topic paradigm shift in labor management, and first of all, this is always thanks for being together and always like giving opportunity to be all the stalwarts of the Odisha, but also to the greatest ever giving, ever generous Jagannath ji. So always a hearty gratitude, and I have served what Bhagya Lakshmi says, a few things that I am really what we could do, what Sashmita was asking from chief guest, that like how we can contribute to as a professional organization. I think I have in my journey, I have actually experimented many things. Like many people, like I just thought that can I have like a book on Safe Motherhood Initiative, Silent Revolution? And Hema says, what an idea. Yes, you go ahead. And that is the thing, Shashmita, to the like what who are going to be in Foxy, that just like don't keep it to yourself. Let all ideas involve into action, and you will see that how people, very good people, learned people, dedicated people join you from the country, all corners, and from all the international world. So this is my experience, and coming to the topic, and somehow God had made entrance of this world very narrow, full of sorrow and the travail. And it is a labor is a painful process. It represents high point of pregnancy, a lot of expectation, emotional climax, which is the pressure of so many things is on the obstetrician and the healthcare team. But actually, everybody has to remember that it is a paradox of modern society that human conditions are becoming sophisticated and planned, but the ability to give birth remains fraught with imperfection. I think this is the thing that we all have to remember, not only as a doctor, but as a people also should remember, so that they are ready to have like any emergency and they cooperate with every treatment. So going through process of labor, how to monitor, how to care, and how to decision making in the labor. It is a really obstetrician, patients, and the woman's fortitude. It is a test of it, and we are like looking for the two traveler, that is mother and fetus, while the obstetrician is bystander. Obstetrician could be too much intervention, it may be too much passive, and it is the right care at the right time. So midwife consider miracle of childbirth as normal and leaves it alone unless there is a trouble, and obstetrician sees childbirth as a trouble, and if he leaves it alone, it is a miracle. So it is something about obstetrician, and it is a, we will say, when we will say for the paradigm shift, that there is a lot of issues that how we should not intervene during the course of labor at many point of time. So how we have to face that is still India contribute to a good number of maternal death. For yes, we are on the right track, a lot of reduction, but still more than 1/3 of maternal death occur around the course of labor, and all criticality occur around the course of labor. So this is very important, and the labor problem is a major contributor still to the criticality and the maternal mortality. So improving the quality of care around the time of birth has been identified as the most impactful strategy for reducing stillbirth and maternal and newborn criticality. That's why we are here. That's why Dr. Tushar took out of many topics that this is the most important, which concern every woman, every obstetrician, and it is a part and parcel of our profession. Why we want to monitor, why we want to have so much of thought process? Because prolonged labor, if remain unattended, can lead to a lot of critical complications: sepsis, obstructed labor, uterus rupture, PPH, perinatal morbidity and mortality. And that's why we have to diagnose dysfunctional labor and do the timely intervention. And we must know what we have been gone through with the labor monitoring issue. Whatever is the thought process, I will really like to point when WHO says that make every pregnancy a positive experience, and a lot of things, but I will be very earthy, like doing that. What are the important points which remain basic? That is a well coordinated teamwork between senior consultant, midwife and nurse. Everyone should have a proper and basic understanding of physiology and mechanism of labor. We should have a good clinical experience and exposure, good patient to nurse to doctor ratio, and set protocol for every obstetrical unit. Now, this is basic, because be it a partogram, be it a labor care guide, actually, when we say that what we respond and how we diagnose, this remains basic, and we should not forget it when we are like putting about a lot of thought process in the paradigm shift. What have been the modes of labor monitoring? Everything is there in our world. Many people only verbally, yes, so it that is 5 centimeter dilated head +1, अभी देख लेना, शायद 1 घंटे में deliver हो जाएगी, शायद 2 घंटे में. Few people can be very good in it, and few people can be very lax in it. Chronological documentation of labor finding, that is the idea. Again, it depends interpersonally that how meticulous and how experienced you are. And that gives the partograph, that is the graphical record of cervical dilatation. And mind it, I really want to emphasize that this classic study of Friedman and Castle came from the low resource setting. It was because as an Indian, actually, when we are like cramming like a Gita and Bible, RCOG and nice guideline, it is good that we understand everything, but it is must that we know ourselves. So the thought came from the low resource setting, and they thought that labor is not a zigzag process. It is a journey which can be predicted, because nature is in order. Human are not in order, but the nature is on order, and the course of labor is predictable, and it is across the globe. So the second thing, how it is that all humans are same all over the world. Then came this classic curve, that is the classic curve, how the labor progress. And then it was latent phase, the cervical was dilated to 3 centimeter. Still we know that the diagnosis of start of latent phase of labor is a crucial thing. It is very subjective, and if we intervene at the time of latent phase, it can result into unnecessary intervention and higher operative delivery rate. It is all the August audience, we know what is active stage, what is second stage, and it is about duration in which there have been the paradigm shift, because it is not 50 minutes for nullipara, 20 minutes for multipara. Now the thought process is that if everybody is fine, maternal as the fetus, both traveler are fine, we can have the flexible and optimum time. I will take 1 or 2 minutes for the standard teaching. And why I'm taking it, because it is a concern so many times in the expert says, actually we don't have to assess the cephalopelvic disproportion. It is just you give observation what is happening and you just see what is happening, because that basic understanding remains with it. What is protraction disorder, what is arrest disorder, and what is considered the dysfunctional labor. So that is the basic of the obstetric, and the teachers like Dr. Tushar Kar, Dr. Mayapati, Dr. Hara Patnaik, and Dr. Lucy, that we actually need that basic strict teaching, because that makes us like capable of taking necessary intervention and when not to intervene and when to intervene. And I'm really concerned for it that the basic and classical teaching of obstetric gynec should remain. We cannot do any experiment unless we are expert in the basics. So this is very important. So the partogram come with the Friedman-Castle graph and what is the primary dysfunctional labor. The point is that it affects a large majority of women, that is 26% of nullipara and 8% of multipara, and secondary arrest which can affect around 6% of nulli and 2% of multipara. So my idea is to emphasize that the labor, dysfunctional labor, protraction disorder as well as the arrest issue is very common in obstetrical practice. Attention to it, that we say once upon a time, even the people started doing the active management of labor, every patient to be put on tramadol, every patient to be oxytocin, and anyway in coordinate uterine activity to be treated with oxytocin. Now issue is with this, now we know that oxytocin augmentation can be very dangerous, can be rapidly dangerous, and we should be very highly cautious about it. And Friedman also says recently that I never meant that the incoordinate uterine cavity, uterine contraction is the indication of oxytocin augmentation. I just demonstrated that we should organize transfer to well-equipped place because he works in the Africa. So with this comes the WHO partograph, and it says very strongly that don't start partograph in the latent phase, and it should start at 4 centimeter dilatation. That partogram has got the 5 section: maternal information, fetal well-being, labor progress, medication, and maternal well-being. And we know it, and we has been done an alert line and action line, which is based on the 10% slowest rate of cervical dilatation. So all the young people, like, what is alert line? When we consider the 10% lowest, which has got the the longest rate of cervical dilatation and action line 2 to 4 hours later, parallel and behind the alert line. Now the 2 point about it, what was negative, that does not take account of the individual variation, and that's why in new labor care guide, when we will discuss, it has been eloped, it has been eliminated. But one thing was important and positive about it, that for the new resident, for the nurses, it gives a really landmark that something is wrong and it is time to act or time to call some senior obstetrician. So everything, when you suddenly new thing come and we think that the old things are obsolete, I think as a mature obstetrician, as a mature teacher, we should think that everything was important and everything still remains there. It acts as early warning system, and it assists in early decision on transfer, augmentation, termination of labor by every cadre of the obstetrical care. So partogram had made a sea change in understanding of labor, and we had all the advantage. We always put it that do partogram. Why? It is a very good pictorial 1-page display. You can change over in the shift duty. It assess labor at a glance, early detection of abnormal progress of labor, serve as a early warning tool. It observe and record feto-maternal condition more objectively, and it is also a legal proof of labor monitoring and management. So this is all thing which we have been saying every time, that the yes, partogram is good, and what the studies also says that it reduces when in units where the partogram is there is reduced prolonged labor, reduced cesarean section rate, and reduced stillbirth. And it is a very good tool and almost no investment. It is just a training and the teaching issue which is there. But a big but is the world is complex and does not goes by our supposed ways. So it is a truth of life, and all over the world, partograph remains suboptimally used in most of the setting. And the second issue is that we are troubled with high rate of cesarean section in profession, in media and people, and we are having backlash with all placenta accreta and the cesarean complications in the next pregnancy. So finally we are. So why all of this, so many studies says that the use of partograph is around 25 to 30%. Sometimes it is retrospectively filled. And what are the causes? Lack of availability of partograph, insufficient knowledge, no training, supportive supervision, negative perception of partograph because we are afraid to see that graphs and that box, heavy workload and constraint in midwifery and patient ratio. Mind it, the few people always think that these issues are not genuine, and we have something lack of commitment, and it is a way of Western world to see at the developing world and the poor world. It is insufficient institutional commitment, but actually I will say the genuine issues were not recognized, and it was a use of 30%, and all the things which were indicated that were considered as a non-use for the partograph, and a lot of guilt that because we did not fill the partograph, so we had this complication. So there come a issue, our own Alokda, who have done a tremendous innovation, what innovative mind India has, that we can have a paperless partogram. And again, I say that it has got its own importance in particular setting, in very low profile, in primary health center. It is 5 centimeter dilatation, 1 centimeter per hour. So add 5 hours, add 4 hours to alert. In 20 seconds, everybody can have a little idea that what is the dysfunctional labor and what we should do. And it is time to take note of the call that something is wrong with this patient and we should go ahead with the senior consultant advice or the referral. It has got its own limitation and it has got its own use. Now, again, a call. I will really say that today, India as a FOXY, we have the past leader, present leader, future leader, potential leader. And we should talk very, very honestly. And when I see the readers' comment and the paper which are questioning the Western world thing, and they say that this is a part of my study which actually led to WHO Labor Care Guide, and it says that the health system strengthening remains crucial. That is the basic what I have told, and we must have the locally tailored guideline. So the overloaded birth attendant can do the best for their women. So it is nothing that always we are in the guilt that we did not do this, because we are doing a lot for every woman and reducing maternal morbidity and improving maternal and child health statistics. We should be proud of, because we could do it for a complex and heterogeneous complication. But we should be honest with our experience. We should be proud of our experience, and we should be learning and de-learning. And what Krishnamurti says, always de-learn and learn, rehearse and practice, and relearn from experience. And experienced are one. And here comes the WHO New Labor Care Guide, which is just published. And it has taken consideration of all the expertise, all the experience, what is different from the older partogram or older monitoring, that it include a new understanding of individual variability of progress of labor, which result in good perinatal outcome. So one woman can have different course of labor in 2 pregnancy, and every woman have a different level of cervical dilatation and different level of approach. Most women do not experience a labor that conforms to the average rate on which partograph was designed. So this is very, very important, that what the alert and action line was taking it, that every woman have got the same rate of cervical dilatation, same rate of progress, but we now recognize because of unnecessary cesarean section. What we say unnecessary, we can say where the cesarean section could be avoided, and now we are recognizing that individual variation. So there is a revisit from Partograph to tool, WHO Labor Care Guide with adjoining publication of user manual to support healthcare providers how to successfully use the tool. So you can click on this thing and they are supporting that how the healthcare worker can really do the thing. So in February 2018, WHO has published consolidated sets of recommendation, and what is included, it is a positive childbirth experience. It includes new definition of duration of first and second stage of the labor. It provides guidance on timing and use of labor intervention, and it aims to improve well-being of women and newborn. What is the principle behind this changed WHO Labor Care Guide? Because we want to have an effective labor and childbirth practice, we want to avoid ineffective and potential harmful practice, and we want to have that every woman is not remember the childbirth experience of very tragic or very painful or very negative, but it has to be a positive experience, and we as a professional care are supposed to give the respectful maternity care. So there are few additions which was not there in the older Partograph or in our mindset, and it is a tool for the labor guidance. It is a guide that where the woman is going, where is the woman is going, and it also support audit and quality improvement of the labor management. A question before us, because it is going to be there, and in Safdarjung Hospital, actually, we have been close touch with the Dr. Achla Batra and the Safdarjung team, Monica and everyone, and we have shared a few sessions with it, and they have found it is effective, and sometimes it can be a really difficult to go with all the guidelines. So there are Indian experience is on the way. So question is, do labor care guide is good for all women? So initially it was applied for only low risk women. Now they say that you can use WHO labor care guide, but we must have the additional specialized monitoring and care. A labor care guide should be initiated. What Dr. Tushar was saying, that when woman enters in active phase of first stage of labor, and that is from 3 to 4, it is now 5 and the 6 centimeter dilatation. With the bar that women and fetus between 3 to 5 or 3 to 6 receive labor care support during latent phase. So this is the sea change again, that we start Partograph only after 5 centimeter dilatation. Now, this is a new WHO labor care guide, and what is different, I have marked with red, that is the supportive care section. Secondly, the second stage of labor, which was not there in the conventional Partograph. And the third section is the shared decision making. When something was going a little haywire, what the obstetrical care provider do for it, what he or she did for that thing. And this is the important tool, because it is there, because when we say that something is going off the way, then what we did, that is the observation, and it is a pressure, or it is a mandatory that we give our reaction. Second stage section is very, very important and a desirable thing, and it assess record. It gives check reference threshold, that for everything, like for the 5 centimeter dilatation, patient can be in 3 to 4 hours in that stage. So it gives the reference threshold. So every person is knowing that yes, it is around 2 hours or 3 hours, and still it is okay. It is within the normal range, and we can do the all waiting, and we can see the watchful expectancy. And again, what the intervention has been done. So this is the few section which I say, and it is a supportive care which is different, which was not at all mentioned in any form of documentation, verbal, written, Partograph, and paperless Partograph, or anything. It is companionship, pain relief, oral fluid, posture. And when it is not there, like pain relief not there, companion not there, oral fluid not there, or the supine position, the obstetric care provide give a circle with the red, and say what was done for it, like he or she was offered option of another companion, why she declined labor pain relief, and what they did do. Baby section is almost same. It is molding, caput, fetal position, amniotic fluid, and the fetal heart deceleration, and it take early late variable, considering that we are not only considering the Doppler, but we are having the CTG machine also. So it is again, it is urine acetone. It is the same thing which was there in the conventional partogram, and the labor progress, and again oxytocin medicine, which is the same. So supportive care is different. You have to encircle what he say. It is say no. It is encircle supine position. It is encircle. So mobility of the patient is allowed, and it is a pressure. Though we talk about it, but when we document it, it is a mandatory that we really think about it. And it is a guideline, like when we start in our institution, how we should fill this labor care guide, and what he say, it is encircling and what is there. Second stage is a different documentation, and it is very, very important, because we all know the complication of second stage are the most crucial, most difficult, and can result into very, very poor obstetrical outcome, be it for baby or be it for the mother. So second stage is very, very important addition in WHO labor care guide, and we have to be very, very careful about it. Just it is no section of the cervical dilatation. It is a birth, and we see that what is the time and what is the duration. Again, important point is that we are afraid of the graph. Why partogram was not used? Because that graph was a little scary, in which in cervical dilatation, you put 4, 5, 6 centimeter and you put cross, and it is a little bit frightening graph, and all blocks are not there. It is easier to any nurse or any resident to fill it up, because you see, and it is a time chart, horizontal and vertically, that when the patient is going into the normal range and when the patient is having the different range. Another important thing you see in the cervical dilatation, for 5 centimeter dilatation, women can be about 6 hours. In 6 centimeter dilatation, patient can be in 5 for the 5 hours. In 7 centimeter, patient can be for 3 hours. 8 centimeter, 2.5 hours, and at 9 centimeter dilatation, she can be in 2 hours. So it gives a range that that much of duration is considered normal, and you have to do nothing. You have not to do the oxytocin augmentation or taking decision for cesarean section, which is actually the issue, because so many cesarean for the dysfunctional labor, because patient is not progressing at the 5 centimeter dilatation for 4 hours. We all know so many times we take after 5 hours, oh, no progress, then let's take for cesarean section, and it takes quite a range that is a normal range, and we can go for the watchful expectancy. What are the aims of this LCG? That is aim for quality of care. The WHO want that expert and end user should use it and keep it concise. And what I was talking, that Safdarjung Hospital has got a good experience as a pilot project, and we have to be concise, and we have to be adapted for it. And with the so many SCB Medical College, Cuttack and Puri Medical College, I think any teacher can take few theses about how the labor care guide is useful, and what is the drawback and what is the positive point about the labor care guide. And very, very important, there have been few questions already that they say it is time consuming, least feasible, and we have to have a robust strategy. And again, I will say that we have to be supportive for our obstetrician, our colleagues, our resident, our nurses in difficult and adverse situation. What Dr. PC sir says, that obstetrician is becoming a rare breed, because everybody is going for endoscopy and infertility. Why? Because they are afraid of legal issue, for violence, for unpredictability, for emergency hours. And if we really want to have that breed of classic obstetrician, which WHO labor care guide and our women want from us, we have to be supportive for them in difficult and adverse situation as a teacher, as a senior, to everybody. And this is again a very, very important beside understanding what is new in paradigm shift. So it is a summary list of recommendation. Again, the facility standard, because if we have the WHO labor care guide, you fill it fully, but you don't have the PPH tray. If you don't have the working good BP instrument, how many of us really have the reflex hammer to see the patellar reflex? And that is the basic necessity. Whatever shift is there, that should be the basic, and never should be our out of focus. And again, this is the thing, this is revisit the second stage, respectful care plan and intervention. So it is a record of clinical rather than ultrasound parameters. So I will say why I'm considering, I am talking about ultrasound, because there has been few papers about the sonoportogram. So to summarize the change, active stage of labor from 5 centimeter with after gold pilot study, they have taken a lot of consideration. Section for second stage of labor, section for supportive care, no longer record strength of uterine contraction. So it is very good, because like teach so many times we are after it, you have not put that bar or the bold, but practically it is not so easy to say that what is called your powerful contraction and what is a weak contraction. So WHO labor guide has omitted it, and it requires deviation from expected observation of any labor parameter to be highlighted. We should highlight and what we have done in response to that. It is bold project, which again says that we disclose that we should go for the later stage of partogram, which actually caused this thing. No alert and action line, we have to have a range of the hours and then we go the guide. So it is good for some time, and it may be a little risky also, because very junior people, unexposed, unexperienced nurses don't have any parameter and they should take their own decision. So actually we need more mature people when we are using this new labor care guide. So alert, circle, respond, plan and act, this is the issue what we have seen. And latent and active phase, very thin and merging line, because it is really difficult to diagnose latent phase. So it is why it is important, because actually it is a personal variation. We don't know when the dilatation starts. Second stage, it is that hours, as soon as the mother and fetus is good, we can have the flexibility of hours. But again, I will put my observation and the diversity in different professional organizations. What WHO labor guide says, second stage 3+1, 1 hour for epidural, multigravitar 2+1. But FIGO still have the set limit of second stage to 2 hours for primary gravitar and 1 hour for multigravitar. They have not changed it. And there has been a many paper which shows that if we prolong second stage beyond 2 hours and 1 hour for primary and multi, it can result into increased maternal and neonatal complication. So we should always, the art of all review of the clinical status, antenatal profile, risk profile, what is the CTG, what is the overall situation has to be there. It is not only hours and dilatation or the fetal head, we have to review and take the decision accordingly. And tincture of time is important. And when we have the watchful expectancy and when we have to intervene, that is the art of obstetrics, which we learned throughout the time. And a companionship, always it is considered one of the best thing, companionship, hydration, change of position and the pain management. And it is like a guide in the journey, much more than a technical tool. So it prompts early recognition and action to improve the quality of care and the woman and her baby receive. So it is a live document. It can change like a constitution of India or constitution of any country, and it is a contemporary, mandatory and the response tool, just than a labor record. So it is a monitoring tool, it is a response tool. What you have observed, what you have done. So this is always there. Now I will say a few questions about it, that there have been a wonderful paper and the response. And one is like, why bother? It is too little and too late and too much and too soon. This is a diversity. For few, it is too much and too soon. Educated, empowered, VIP patient, too much, too soon, too little, too late. rural patient, poor patient, in government setting. So it is like a world how it is different, and we have to be care about it. We should have the courage to ask a question. And there has been a few issues that it can be very intensive, and we really need a good nurse to laboring patient ratio, as well as the experience of that nurse and the obstetrician. So again, part of my project says that the local guidelines and the local practices should be considered, and we should be very, very flexible and take the decisions accordingly in the labor management. What are our resources? What is the patient profile? What is our country status? And what is our backup system for the anesthesia, for the cesarean, and for the everything? So do new labor care guide clear path, or only LAs, or give responsibility solely on knowledge and skill of attending person? It is our experience which will tell with us. So I think I have covered all these things, that what is the labor care guide, new things, what it is, how it is different in our perception and response, how WHO wants us to modify us according to our labor unit practices and the local practices, and we really need to have a good experience in our setting. And ground realities, I will say few which I have been observed in busy labor ward. Birth companion is not allowed, especially at time of delivery. It may be good, it may be a little, but sometimes it is not so good. No defining role and responsibility, as well as eligibility of birth companion. So when we talk of birth companion, do we have certain sort of readiness that who will be birth companion, who will have the good clean clothes, she will not interfere in disease, and she will not interfere in other labor process. So this is important. How many people in our country have got the facility of epidural labor analgesia when we have got the dearth of anesthetists, even for elective and emergency surgeries? So we need to have our own experience, and these are the questions where the 4 to 5 centimeter patient will be cared of, and if something goes wrong, then how we should have the thing. Last word about the WHO labor care guide, say 5 hours, 11 hours labor. And there are what we say too much for too few. So modern is complex and T-savvy, and now the sonopartogram has come that we need sonography to see the descent, to diagnose the occipito-posterior position. How we will do this training issue? We cannot evaluate by the pervaginal examination by strength of uterine contraction. And tomorrow generation will be that like a technical savvy, and how many ultrasound machine we have got for so many patients. So actually the world is confused or world is clear. It is a question to us. So it is some papers which say that sonopartogram is good, especially in diagnosis occipito-posterior position. They say because it is in research setting that it is a good diagnostic tool, but issue of training and experience, right image, right interpretation, especially in advanced labor with uterine contraction, where we should invest. We should invest in basic teaching, basic exposure, or we should go for the complex and the technology. So this is something, a true question before us, and we should honestly try to answer it, and we should bold enough to put our experience. This is the way which I want to communicate to all over. So who can use technology with wisdom, and we need investment on what with the 27 million deliveries and the 50,000 maximum obstetrician. It is Manita project that every skilled care worker should be able to detect complication, handle complication, referral in good time and frame. And the resource strain, human resource is the big issue in our country, all over the world. For the good, that amount of good care, we need a lot of nurses, lot of doctors, and we don't have 24/7 in the primary health center or the comprehensive like first referral unit, where a lot of rural women, lot of people are delivering because of Janani Suraksha Yojana and NRHM, and we have to be ready for create that human resources structure. I will say Foxy Manita project, I've been like since 13 years, I think it is around 8 years, and I have joined with the basic Manyata when it was a project in the UP and Jharkhand, and traveled in all possible places. And now we have around 1500 facilities. And this is just last meeting with Raipur. And you see a person in Sudan, the nurse is sharing her experience, that how she is empowered with the knowledge, what the right clinical practice during labor management, infection prevention, oxytocin, active management of third stage of labor, detection of PPH. And this is the way, this is our experience, which actually going to give us honor, which we can do something to our women, and we must join hands. Still, we have only 1500 facility when the COVID virtual training program is there, and we have 30,000 gynecologists. Out of this, 30 to 40% are private practitioners. So in private practice, there is no Lakshya program, there is no training issue for the paramedical, and actually obstetrician is lost 24/7, 365 days. She is catering for the obstetric patient and no teamwork. So how Manyata has intervened and Foxy has intervened, it is the, like, we should be proud of it, but we need much more beyond it. So while women has been delivering more or less in same way, there is now sea change in the family's psychological response to the labor. And where is our role as obstetrician when we place new methodologies and new tools for monitoring of labor and our response? So I am putting more question and answers as well, and the potential experience as well, and the positive experience as well. So it is an armamentarium WHO new labor care guide for facing today's challenge, and we need to have our own experience. India has done such a good work in COVID time, much better than the Western output. And it is Dr. V.P. Pally's Kerala Federation Confidential Inquiry of Maternal Death. I got this book around only 10 days ago. And this is what Sushmita was saying, what as a Foxy, as a professional organization, we can really do it for our women. This says suicide is one of the important cause of maternal death. So this is very important thing. And we should have our own recommendation and our own implementation. We need to intensify our nurse human resource, no declassify. This is very important. Hierarchy, classify, big city, small cities, but humans are same, passion is same, and profession is same, and woman is same. And this is important that we always take whenever we took any new labor care guide, any paradigm shift, because the science remains same. We change our perspective to observing for them. So learn from the history and observe with the scientific choiceless awareness what is actually happening, and do this. Is finally, it is right amount of care at right time, delivered in a manner that respect, protect, and promotes human rights. And that includes everyone's right, healthcare provider, woman, family, irrespective of class, their location, residence, and everything. So to conclude, a lot of work and lot of thought process has been done in making this paradigm shift in the WHO labor care guide. Use in our setup, see how it is working, organize your experience, organize our experience, give them respectful voice, and see that how we can really use for the reduction of cesarean section rate, for the respectful maternity care, and reduce, and with the good maternal and perinatal outcome. Hearty thanks for joining the journey. I've traveled pan-India from very small cities to big cities for conducting so many workshops, and I'm a really contented soul. What we have contributed, what we could do for our colleagues and our women, and there is much more to do for it. And with this, I earnestly request for your full-hearted vote and support for my candidature for Foxy President. Election link is already on. What Dr. Tushar says, vote for the best, and I can say I am the very best for this post, and I could do, taking along everybody's experience, respectful voice to every obstetrician experience. That has been my way, that has been our way from the Odisha Society, and that will be the future way. Thank you very much.
Dr. Barsa, have I the privilege to speak now?
Yes, sir. Yes, sir.
Yeah. First of all, Dr. Sadhana, excellent presentation, very good, and it really a very thought-provoking topic. Why there was a shift or paradigm shift in labor management? Because over the years we have been seeing a country like ours all over the world. See, antenatal care has improved. Modern gadgets in labor management has improved, but labor monitoring has not improved because we do not, the seniors do not have time and patience for monitoring a labor. They depend on the juniors for monitoring the labor, and it seems that sometimes it so seems that a packed labor room with so many labor patients in a labor ward, management becomes difficult. So the concept started that if we can have a pathograph with each patient, when the consultant comes around and gives the visit, she can immediately decide that this patient has gone into dysfunctional labor. You should intervene early. You should go for this early. And so much of stress was given by Government of India on pathograph. And it is very simple, but most of us today, even today, do not use pathograph, even though that is why, and a slight change in the labor protocol, then you immediately jump that no, I am the fetal distress, I am going to go for a cesarean section. That is why the cesarean section rate has gone, and it is more and more in private institutions. We all know that. So that is why this thought of a change in the labor management protocol has to be there. If you remember, during the tenure of Dr. Sam Desai, they started a program, the protocol of program labor. He has conducted many things which was there, that a day care management of labor induction, and if you do not deliver by evening, go for a cesarean section at night, which was not successful in fact. And this paradigm shift, which we tell, it is a good thing that you have to go big paperless, and you can early diagnosis of dysfunctional labor and change in the duration of first stage and second stage, show that early alert should be done. And there are a lot of things to be told, and with this brief time, let me conclude this. And first of all, I must say, Dr. Sadhana Gupta, you are a well-accomplished person. You have traveled across far and wide of the country, and now that you are contesting for President Foxy, for which the election is already on, and I wish you all the best and good wishes for your accomplishment, and may God bless you, may Lord Jagannath bless you. Suchitra, one word for you. Dr. Suchitra Pandit, our past President Foxy, is a very, very academically, very strong, smiling, ever enchanting personality. I forgot that you took charge as Joint Secretary during AISOG 2002 and 2002, when Dr.
Usha
Saraya Madam took as the President Foxy, and she got the award, Korean award that year, Dr. Sadhana was telling. Dr. Suchitra Pandit is contesting for Foxy representative to FIGO this time again. Both the great stalwarts are competing, and Foxy is an organization of intellectuals, academicians, and whatnot. And I wish both of you all the best, good luck, and may God bless you in all respect. I will remind you that our dear Dr. Sasmita Swai, Professor Sasmita Swai, is contesting for Chairperson, Family Welfare Committee Foxy this time. So please support her, bless her, guide her in her endeavor as this. And with these words, with my colleague, Dr. Bhagyalakshmi Naik, and the guest of honor, Professor Maya Padi, and Chief Guest, Dr. Suchitra Pandit, Secretary Sasmita Swai, and Joint Secretary Ajit Naik, and Dr. Tusarkar as the helm of affairs as President AOGO, and the dynamic lady, Dr. Barsa Sahu, as the Master of Ceremony. We wish you good luck from Association of Obstetrician and Gynecologist of Orissa. To both of you, all the best, and thank you very much for giving us AOGO the opportunity to meet you, the great personality today. Thank you.
Thank you so much, sir.
Thank you, sir.
Is anybody interested to ask any question? Or I have just concluded without asking anybody that if it is not there, if anything is left, you can add.
Dr. Tushar's comment, because he's like if he
Dr.
is there.
Tushar, Dr. Maya, and Dr.
Yes.
If they are there,
Yes, Dr. Maya.
Yeah.
It's late. So with this we come to the session. So thank you, Suchitra madam, thank you Sadhana madam, and thank you all our dignitaries who have joined us, and delegates also who have joined us. So with this we conclude today's academic session.
Can I say something?
Yes, madam.
Can I say something? I think I was hearing the talk in between. I had a webinar to talk. That's why I went there. But it was a very extensively and a very, very well researched talk. And Hara had, he has summarized everything very well. And I would like to say that, yeah, Dr. Sadhana is a very, very hardworking person. So, it reflects in her talk that real zest for working for our own women can be seen in her talk. So thank you very much, Sadhana. I enjoyed listening to it. And once again, I wanted you to see the picture behind.
Yeah.
I've got this plaque when I came for the Yuva Foxy to Bhubaneswar. So this is always there in my room. So a lot of my patients, when they come, I have Odissi patients coming, and then they say, "But how do you know this?" I said, "Because I've been to Bhubaneswar, Cuttack, and Puri so many times." So we both of us need everybody's blessings.
Okay,
and all the best to Shashmita.
Thank you.
Thank you.
Can conclude, Varsha.
Yes, sir. On behalf of AOG, I would like to give the official vote of thanks to our chief guest, Dr. Suchitra Pandit Madam, our speaker, Dr. Shadna Gupta Madam, our guests of honor, Dr. Maya Padi Madam, Dr. Lucy Das Madam, our chairpersons, Dr. H.P. Patnaik Sir, Dr. Bhagyalakshmi Naik Madam, and our AOGO President, Professor Dr. Tusharkar, and Professor Dr. Sasmita Swai Madam, our AOGO Secretary, and all the delegates who have joined this beautiful session. Thank you. We were privileged to have you all amongst us. Thank you so much.
Thank you, Varsha.
Thank you, Ajit.
So lovely coordination and a sweet voice. Thank
you. Thank you, ma'am.
Thank is also there.
Thank you, Ajit sir.
Backbone of this stuff. Yes.
Thank you, sir. Thank you, ma'am.
Thank you, ma'am.
All the best again.
Thank you, sir. Thank you.
Thank you, doctors.
इसको ये पूरा कर